I'd like to introduce Dr. Ann Moore, today's presenter. Ann Moore is the Women's Health Clinical Trainer for the Division of Family Planning and Wellness at the Department of Health. Dr. Moore received her undergraduate and master's degree from Vanderbilt University and her doctorate from the University of Missouri at Kansas City. She holds a dual certification in women's and adult health and has maintained an active practice in Nashville for more than 25 years. A fellow of the American Academy of Nurse Practitioners, she currently serves as an associate editor for Journal Watch for Women's Health and is the editor of Updates in Clinical Medicine. Dr. Moore has authored numerous publications and is frequently invited to speak nationally and internationally on topics related to the health of women. Now I will turn the floor over to Dr. Moore.
To everyone. Thank you, Megan, and thank you to everyone who's on the call this afternoon or this morning, as the case may be. As we go into this presentation, I like to pause and remind myself that this is very detailed. And so why are we talking about MS? As I would assume that the majority of us would be perhaps women's health-focused providers. And certainly I'm not expecting that as we leave this presentation after 30 minutes to an hour or so of a didactic content presentation that we're going to know everything there is to know about MS, because we're not. But what I think we have to take away from this is that there is a significant proportion of the population that is affected by this disease, and that we as providers of healthcare to women should have an understanding, at least in a broad stroke or from a broad perspective, of what this entails as far as the implications with respect to women's health care, the implications from a perspective of reproductive health, and certainly a bit of an understanding of what these patients can anticipate as they go forward with their reproductive health plan, and a little bit about the pharmacodynamics, pharmacokinetics that are involved with the different kinds of medications that are employed in the course of their care. So are we going to be experts about MS? Absolutely not. Are we going to hopefully have a better understanding of what this looks like from a disease process perspective and how we can maybe have a better appreciation of how to counsel and guide our patients through this process? I hope so. So with that, we're going to move through this, and I'll start by giving the acknowledgement as to how this program was made possible and some of the declarations of disclosure for the folks who helped put the program together. So here are the learning objectives, and what we would like to do, demonstrate current knowledge about MS, go over symptoms, diagnosis, treatment, and pain management, improve health outcomes among patients living with MS. Some of how do we help folks deal with a chronic condition, and review some of the evidence-based information about how to best deal with issues like chronic pain management. manage the treatment of women with MS as an interdisciplinary approach, certainly, and then specifically look at the reproductive health issues as we move forward, as those of us that deal with contraceptive coverage for these women, sexuality and sexual health issues, and pregnancy. So I think it's helpful to start with a case study and hopefully follow this through. So we're going to have Tamara. She was diagnosed with MS 8 years ago at the age of 22. She is currently being followed by a neurologist. She initially declined treatment, but initiated weekly interferon beta 1A injections 3 years ago after she had a relapse that resulted in transient lower extremity weakness and some impaired urinary retention. IV steroids improved her symptoms, but she's had residual lower extremity weakness and poor bladder control. So now she has an indwelling pubic catheter. She has annual follow-up with a local urologist. She uses a cane for walking long distances because she's got stiffness in her legs caused by her prolonged physical activity, or caused by prolonged physical activity. So that's what's causing her stiffness, I should say. And her GYN history is notable for regular menstrual periods. They last about 4 to 5 days, and she never has been pregnant. So this is looking at her current medication profile. So she's on sertraline for mild depression. She's been on that for 2 years. She's on baclofen 10 milligrams twice a day for spasticity. She again is on the interferon beta 1A 30 micrograms, IM injection once a week. She's taking 2,000 units of vitamin D daily and 1,000 units above a 40-degree latitude. And one of the tidbits that I learned was that, even with this particular geographic designation, that migration from one area to another, that immigrants and their descendants that assume a risk level, they will assume a risk level of a new geographic location rather than their location of origin. So if they move to that higher geographic location, they will assume a risk. And Caucasian women, particularly, again, Northern European ancestry, tend to have a higher risk. Women are 3 to 1 more likely than men to have risk of MS. Current estimates are that, again, there are 400,000 cases in the U.S. The risk of worldwide is certainly significant. In the United States, the risk of the general population is 1 per 1,000, or 0.1%, and then the estimated worldwide incidence is 2.3 million people. So again, the numbers I think are pretty compelling. So a little bit about the natural history of multiple sclerosis as we go through this particular slide. The exact pathophysiology has yet to be determined, but there is consensus that it is an autoimmune disease that affects the central nervous system, that includes the brain, optic nerves, and the spinal cord. The initial trigger for the immune system is unknown, but it may be provoked by destruction of myelin in response to an infectious agent or by dysregulation of the immune system. The autoimmune response targets and destroys myelin surrounding nerve axons and oligodendrocytes. Inflammation is a hallmark characteristic of MS that precedes demyelination, axonal injury, neurodegeneration, and gliotic sclerosis. The demyelinization results in the formation of plaques or lesions on the myelin sheath, which in turn impair nerve conduction. This will result in diffuse neurologic symptoms, including impairment or loss of vision, bladder and bowel dysfunction, and cognitive changes. So again, it's a variable disease. The course of MS usually follows a variable pattern over time. About 80% of patients initially present with an inflammatory course characterized by relapses and remissions of the neurologic symptoms. The frequency and severity of these events is generally unpredictable. The course is quite unpredictable between patients, with some having only mild symptoms for many years, and then others experiencing more aggressive disease that can lead to rapid development and disabilities. Over time, the relapses occur more frequently that can cause progressive disability that is likely due to neuronal degeneration just overall. A minority of patients present with primarily degenerative disease characterized by progressive neurological impairment without clearly defined clinical relapses, and this is known as primary progressive MS. So some common symptoms of the first episode of MS can be sudden or insidious. Some patients experience severe symptoms. Others have such mild symptoms that they may not even seek medical care. So it's extremely variable due to location and the severity of the lesions within the central nervous system. On this slide, you can see the most frequently reported symptoms associated with the initial episode. More than 10% of patients report sensory loss, optic neuritis, weakness, paresthesia, diplopia, I can't even speak this afternoon, diplopia, and ataxia. And that's where you see the encapsulation here on the slide. And some other common symptoms. Fatigue is experienced by about 90% of patients, and it's the leading cause of work-related disability. Moderate to severe spasticity affects about 30% of patients and is often accompanied by painful spasms that can interfere with ambulation, work, and the abilities to perform activities of daily living. Sensory symptoms are variable. These can include paresthesia, hyperesthesia, and sensation that body parts are swollen, tightly constrained, just kind of encapsulated even. Impaired memory and attention difficulties with problem solving. Decrease the ability to process information. Visual disturbances can include decreased acuity, dimness, changes in color perception, vision loss. Ataxia can present with tremors, lack of coordination of the head, the trunk, or the voice. Depression is estimated to occur in about 50% of people with MS, and suicide is thought to be about 7.5 times greater compared to the general adult population. Sexual dysfunction can include loss or decreased libido. There's an impairment typically in genital subtypes of MS. There are 4 of them. There's relapsing remitting, which is clearly defined disease relapses followed by a full recovery or with sequelae and residual deficits upon recovery. The period between relapses is characterized by lack of disease progression, estimated to affect about 85% of all patients. Okay? Primary progressive, the disease progression is evident from the onset of occasional plateaus and temporary minor improvements. It affects about 10% of patients. Secondary progressive, initially relapsing remitting disease a course that is followed by progression with or without occasional relapses, minor remissions, and plateaus. And this is approximately 65 to 70% of patients with relapsing, remitting, and they develop secondary progressive. Progressive relapsing is progressive disease from the onset with clear acute relapses or without full recovery in periods between relapses characterized by continued progression of disease. So, yeah, that's confusing, I will grant you. And that's just kind of a quick snapshot of, how the four characterized or clinical subtypes are kind of identified or blocked from a standpoint of how essentially you would treat them, from a pharmacologic standpoint. All right, so multiple factors, again, that influence the pathogenesis of MS. Infection, genetics, environment, vitamin D, and then hormones. I won't go into these in great detail because, as I said earlier, there's not a real clear focal point for causation here, and it's felt that many of these issues kind of interlock with each other, and so many of those are suspect. For example, the infectious agent, there is a suspicion that that infection is associated perhaps with Epstein-Barr virus. There appear to be genetic associations, certainly, and there appears to be a histocompatibility issue having to do with chromosome 6 that has been cited in the literature, and certainly that's something that y'all can look into if you're interested in that particular causal possibility. More than 80% of individuals with MS do not have a first-degree relative with the disease, but there's been certainly the relationship with a genetic piece that has been part of the equation for quite some time, suspecting that that genetics does have a causal link with MS. But then again, as I said, 80% of folks don't have that, don't have a first-degree relative with the disease. The geographical gradient suggests that maybe ultraviolet light exposure from the sun could play an important role in acquisition of MS. Low levels of vitamin D have been associated with an increased risk. Gender differences, and so on and so forth. So, does the gender difference perhaps buy into the idea that hormones play a part in increasing your susceptibility or your incidence or risk of acquiring MS? So that's why all of this kind of goes around in a circle, because we really don't know the specifics as to why someone's at risk or why someone's risk factor might be increased. It's just an interplay of all of these features. So disease-modifying treatments, and this is kind of where things get really complicated if you weren't confused already. And this is why the neurologists handle these disease processes, because they are complicated and because the medications that are instituted for treatment are not benign. And so those of us that deal with the women's health reproductive piece of care for individuals that are suffering from MS or being treated for MS, we kind of come in and out of this picture playing our unique and important role. But, we always have to keep in mind that these medications, as I said, are not benign. And we, I think, turf back and forth, between neurology and the women's health provider in trying to, give complete care, but always with the understanding that, that there's a line between, what we're comfortable with managing. And hopefully this will help not make the line so concrete that we'll have a little greater comfort level with at least understanding of some of these medications. So currently there are 10 disease-modifying treatments that are approved by the FDA for treatment of patients with the relapsing forms of MS, including the secondary progressive MS for patients still experiencing relapses. One DMT is also approved for the treatment of secondary progressive MS. These 10 therapies include 3 formulations of interferon, including interferon beta 1A and beta 1B, and we'll look at the differences between these in the next few slides. In general, DMT therapies are intended to reduce the frequency and severity of relapses, to reduce the accumulation of new, damaged, or active disease areas or lesions, and slow the development of disabilities. Across clinical trials, comparing specific DMTs with placebo, all MS relapses were reduced 28 to 68%, but none of the treatments offer a cure. So I think that always needs to be certainly kept in perspective. So here is a slide actually that looks at pretty much everything at a glance. So interferon beta A was the first DMT to receive FDA approval, again based on results from a phase 3 trial that significantly lowered the relapse rates as well as lower rates of disease progression and no significant increase detection of MRI lesions. There are 2 formulations of beta 1A, including an IM injection once per week or a sub-Q injection 3 times a week. Glatiramer acetate is administered daily by subcutaneous injection, and initiation of treatment with the interferons and glatiramer acetate is recommended as early as possible. Randomized clinical trials confirm the efficacy of interferon beta formulations, that's beta 1A and beta 1B, as well as glatiramer, if I'm saying that incorrectly, y'all will have to forgive me, glatiramer acetate as standard first-line therapies for MS. So beta 1A and beta 1B as well as glatiramer acetate. These agents significantly improve relapse rates, percentage relapse-free, intervals between relapses, as well as significant delays in decreased severity of disability upon progression and declines in MRI measures of disease activity. Okay? Evidence from randomized trials suggests that early versus delayed treatment is associated with a reduced risk of disease progression and 40% reduced risk of disability progression at 3 years. So huge influence, again, once early implementation of medication therapy is initiated. So here we see those 3 actually side by side. And, you know, some of my notes here talk about, you know, how these are manufactured, you know, the interferon beta 1A versus beta 1B. I won't go into all those details because I think, you know, there's only so much that we're able to absorb in a 45-minute to 1 hour conference call. But suffice to say that these do a good job as far as the DMTs. And actually were some of the first ones that were out there to attack the problem. So I'm going to not go through all of the very detailed clinical background on these. Okay. Now, fingolimod is thought to promote retention of lymphocytes in the lymph nodes, which prevents these from crossing the blood-brain barrier into the central nervous system, decreasing damage to nerve cells caused by the inflammatory process that is associated with MS. It was approved in 2010 by the FDA for the treatment of relapsing forms of MS to decrease the frequency of these relapses and, again, delay disability progression. Now, mitoxantrone is an antineoplastic agent that's used to treat cancer, but is also demonstrated to be efficacious for the treatment of MS. It was approved for patients with secondary progressive MS, as well as progressive relapsing MS and worsening relapsing remitting MS, characterized by clinical episodes without complete remission that result in increased progression of disability. as we move forward. This, again, looks at interferon beta-1a sub-Q and natalizumab, So the interferon beta-1a is also approved, as I said earlier, as a sub-Q 3 times a week. It's associated with a significantly lower relapse rate, again, a longer duration between relapses, higher incidence of patients who are relapse-free, and a decreased incidence of active lesions seen on MRI, delayed progression of disability. So it targets all of those areas that we're trying to hit or objectives we're trying to achieve with these DMTs. Natalizumab is a monoclonal antibody, and that interferes with the movement of potentially harmful immune cells across the blood-brain barrier. So again, different MOAs or mechanisms of action, but the strategies I think are kind of compelling with respect to how these might work to make improvements and certainly to decrease symptomatology. Dimethyl fumarate and teriflunomide. So dimethyl fumarate, or BG12, is indicated for treatment of patients with the relapsing forms of MS. It's associated with a significantly reduced rate of relapse and also with reduced numbers of lesions on MRI. Teriflunomide is also indicated for treatment of patients with relapsing forms of MS. It also is associated with decreased relapse rates or reduced numbers of relapse rates, disability progression, and lesions on MRI compared to placebo. Now, some of the common side effects associated with DMTs, and you can see them here: flu-like symptoms with interferon beta-1a, and with beta-1b, again, flu-like symptoms that diminish over time. Injection site reactions, which I think are probably not surprising. There's an escalating dose schedule: 7.5 micrograms on 1 week to 15 micrograms in week 2, 22.5 micrograms week 3, and full dose of 30 micrograms in week 4. And so that step up, tends to be, from a standpoint of side effect profile, tends to be helpful in making symptom management more tolerable. Another strategy is taking interferon beta-1b at bedtime or pre-medicating with Tylenol or ibuprofen. So, patient education about aseptic technique and using in performing injections is also an important strategy that maybe we tend to overlook, but certainly can be something we can reinforce. And then looking at some of the other meds, glatiramer acetate, again, injection site reactions, fingolimod, headache, flu-like symptoms, diarrhea, back pain, liver enzyme abnormalities, and cough. So again, we do sort of keep the idea of monitoring hepatic function, is something we strategize or we want to keep on our radar. But again, we're not doing these as far as prescribing these meds. But this is something that will undoubtedly be covered by neurology or the folks that are titering and managing these medications for these folks. Mitoxantrone. Blue-green urine 24 hours post-therapy. Probably need to tell patients about that because it's going to be a little disturbing if they hadn't anticipated it. And then, again, as I said in the early part of the presentation, these are not benign medications. If you look at things like infection, bone marrow suppression, thinning hair, nausea, hopefully, and I'm sure these patients have been pre-warned about some of these fairly significant side effects that they can encounter. Just because the medication is working, and this is just some of the fallout that comes from the use of these particular drugs. Because they are considered pretty heavy. In the whole litany of medications that we offer, they can have some pretty significant side effects. But again, I think it's important I have several or more patients that have MS. And I think it's also helpful for us to appreciate what they're experiencing. And, aside from the fact that they have chronic disease, to step back for a second and get an appreciation of what they're having to endure, from a perspective of just trying to stay as healthy as possible. It's not an easy road. So, and I know that's a firm grasp of the obvious, but I think, folding this into our perspective or perception of our patients is helpful every now and then. Again, we're looking at natalizumab, headache, fatigue, urinary tract infections, depression, lower respiratory tract infections, joint pain, chest discomfort. And if you look at the symptoms just associated with the disease itself, it's kind of squared or trumped with the idea that you're combating the disease process with medications that can cause a plethora of side effects that aren't particularly pleasurable or even tolerable. And dimethyl fumarate, flushing, diarrhea, and of course you can read these. And then teriflunomide, same, abnormal liver function test, nausea, alopecia, you're going to lose your hair. I mean, it's just, again, kind of a distressing profile. The warnings associated with DMT, disease-modifying treatments, or DMTs for MS, and you can see these as well. And you would think increased risk of a depression, suicidal ideation, and other psychiatric disorders, hepatic injury, anaphylaxis, so on and so forth. And with interferon beta 1b, the same. So typically these folks are followed with CBCs, differentials, chem panels, and associated tests, as well as I would suspect a fair amount of counseling and guidance. And I would hope a fair amount of follow-up from the neurologic primary care provider who's taking the lead or quarterbacking this situation. But as we come in, and we'll see as we do our follow-up on the case study, I think it's important to acknowledge that it may not just be about this person's reproductive health that she's seeing us. That we do have to fold into the total picture of overall care, and I think this kind of reboot enables us to do that. So again, some warnings are associated with the other medications that we reviewed: bradycardia, macular edema, fetal risk, and then here are some others. By the way, JC is John Cunningham virus that my notes say usually results in death or severe disability. And you see that in the provider she happens to be seeing at the time, like, here you go. I don't feel like writing them all down for you, but and so it's up to us, I think, to some extent, to know what these are for, because she may just give us the running list and may not be as willing to put them in little categories to help us out. But this kind of gives you an overview of what some of these other meds might be prescribed for, what they're trying to accomplish, as do these. Amantadine, aspirin for pain, antidepressants. Maybe she's on some amitriptyline, for example. Anticholinergics if she's having continence issues. Botulinum toxin for bladder issues as well. Just a compendium here in these. slide, the one before, of adjuvant medications that may not make sense other than, you may be able to recall that it could be for, therapeutic treatment of some of the cofactors that go along with her disease process other than, falling into the category of a DMT. And then here's some more. Increased water. These are, combination of holistic as well as pharmacologic interventions. Vaginal lubricants for sexual dysfunction. Vibrators. She's got decreased arousal, which is not uncommon in folks that have MS. We hopefully have gotten to the point where we feel comfortable discussing arousal issues with our patient and beyond that. And, particularly identifying that those may be issues with our patients would probably make you the hero of the moment in situations such as this. Okay. So here are some comorbid medical conditions, as if the MS weren't enough. These folks are likely to have things like autoimmune disorders on board as well, thyroid disease, diabetes, and B12 deficiency. So, hopefully, again, there is someone who is looking at the whole picture. I think, unfortunately, even though we're supposed to be more covered by insurance, which I don't believe is happening, in my arena, from what I'm seeing, but hopefully there's someone who is taking a broader view. There is someone looking down from 30,000 feet and collecting all this information to give coordinated and comprehensive care to the whole person. So vaccinations, similar to vaccination recommended for non-affected patients, patients with MS should be immunized for things like diphtheria, tetanus, influenza, and pneumococcus. Vaccinations aren't recommended for patients with MS, including things like live vaccines. So measles, mumps, rubella, varicella vaccines. There's insufficient data and varicella vaccines for that matter. There's not enough data to recommend HPV vaccines, meningococcal, and zoster at this particular point. Interferons don't seem to attenuate the effectiveness of vaccines, such as seasonal flu vaccine, if that's a question. So this kind of gives you a little bit of an overview of how well they'll be utilized and which ones we should avoid. All right, so what about physical activity? And it's interesting, the data. This is taken from 9 international trials. The qualitative analysis showed favorable evidence for the benefits of exercise, including muscle power function, tolerance function, mobility-related function, and improved mood. Supplements in MS. So vitamin D, it is felt has several important implications in the care of patients with MS. It has an immunoregulatory effect and offers preventive and disease-modifying effects. So it also, of course, helps with bone density, and patients with MS are at increased risk of osteopenia and osteoporosis. Potentially compounded by the fact that immobility is often part of the picture. There is a small body of evidence that suggests that omega-3 fatty acids may slow the progression of disability with patients with MS and may also improve physical and emotional functioning when taken in combination with interferons or glatiramer acetate. Okay, there's no evidence of a therapeutic effect of vitamin B12. But a small number of patients have a vitamin B12 deficiency and might require supplementation. So it's generally well tolerated. Now, with respect to echinacea, it is contraindicated in patients with MS, particularly those treated with interferons or methotrexate due to the hepatotoxic effects. So for people who like to think that echinacea is a be-all to end-all, that needs to be something that we steer clear of. So let's get back to Tamara. Her lab evaluations, including a CBC, chem panel, TSH, UA, and vitamin D and B12 levels were done. We referred her to PT for evaluation and consultation regarding her lower extremity spasticity. We encouraged 20 to 30 minutes of physical activity a day, especially for lower extremity problems. We discussed baclofen taper with her neurologist because that actually may contribute to depression. Encouraged adherence to once-weekly beta-1A injections. Discussed the need for the indwelling pubic catheter versus the concept of a self-catheterization with the urologist. And then reviewed her lifestyle issues, including the importance of about 7 to 8 hours of sleep at night, continuing the vitamin D level vitamin D implementation or supplementation, waiting for the lab results to come back, started the use of omega-3 fatty acid, and avoid anything containing echinacea, and then we offered flu vaccine. So, okay. Now this thing doesn't want to go forward. Hold on. So we encouraged her adherence to her disease-modifying therapies or treatments, monitored toxicities or side effects, any kind of reactions to medications, checked her CBC and her chem panel every 6 months, or had someone do that, whoever was managing those meds, checked thyroid function, vitamin D and B12 on an annual basis, vitamin D and omega-3 supplementation, again, was encouraged. Inactivated vaccines, we reminded were safe for patients with MS at any time during their life cycle, including during pregnancy. And she reports for an annual physical exam, says she's engaged. The exam was normal. There were no changes in her medication. She is still using the indwelling catheter, and when asked about concerns about sexual health, she gets, embarrassed and tears up, and, so there's a problem. So just as an overview, the frequency of female sexual dysfunction in women with MS is higher than that in the general population and is estimated to be about 40 to 74% in women that have MS. And again, those problems can include lack of or low libido, impaired arousal, decreased vaginal lubrication, and anorgasmia. So again, here's kind of a list, and it's kind of overarching just about everything: arousal problems, pain disorders, orgasmic problems. Again, they're limited with respect to positioning. They have to plan. They have to have bladder control, at least a prospectus for what that's going to be. It's not something that can be spontaneous in their world. There's decrease in sexual satisfaction. The idea of urine odor, for example, may be something of concern for women. Inability or limitations in intimate touching. This woman's got an indwelling catheter, for example. So, lots of potential negatives with respect to her sexual health or sexual identity. So with primary, we've separated this into primary, secondary, and tertiary sexual dysfunction. So in the primary realm, you've got sensory genital dysfunction, difficulty achieving orgasm, decreased vaginal lubrication, and decreased libido. And it's the neurologic damage that's causing the primary sexual dysfunction domain here. The secondary issues are kind of, again, impactful, but it's a compilation of what goes on top of what's happening in the primary domain. So fatigue, cognitive dysfunction, spasticity, tremors, neuropathic and other types of pain, bladder and bowel dysfunction, and then effects of medications. It you're building on that primary involvement or that primary pathology, if you will, that is related to the neurologic damage. And then the tertiary dysfunction is caused by the psychological, emotional, social, and cultural aspects. Just having a chronic, long-term disabling disease. And that's when you get, some of the self-image pieces that come into play. So what are your treatment options here? You've got to treat the source for lack of desire, depression, fatigue, chronic disease. It could be a potentially long list. You got to encourage women to initiate sex. We recommend lubricants. Lubricants are not the be all to end all, but certainly can address one problem that women may have. Local or systemic hormone therapy, focus on alternatives to intercourse as a source of pleasure. So in something that will increase stimulation. We mentioned use of a vibrator earlier, the magic bullet, things that can, again, heighten sensitivity if areas don't respond as response would be typical, or perhaps maybe as response had been felt before. So, we got to be a little freer in conversation to be able to address the concerns these women may be having, or at least to broach the subject. Plan sexual activity when fatigue is less, so in the morning. These women are starved to some degree for rest and sleep. Positions that are less stressful or less taxing physically. Take medications an hour before intercourse is planned or sexual activity is planned. Anticholinergic medications, again, can be drying to some tissues, but may be helpful for bladder. So those can be timed. Bladder emptying, of course, beforehand. More intense manual oral stimulation with respect to lubricants, something like coconut oil that is really soothing to the tissue. One thing about lubricants is that can also decrease sensitivity. So it's a balancing act of how much is too much and what's going to be soothing to the tissue, but also not diminish sensitivity. Pharmacologic treatment for depression, that's a double-edged sword. So you want to have the depression treated, but you don't want to blunt the sexual response, as is often the case with SSRIs. Perhaps use of something like a bupropion on top of that to enhance sexual function. Psychological treatment, sex counseling with an emphasis on pleasure-oriented outer course. Well, first you got to broach the subject before you can get into any of this, as y'all know, and that takes some time, and it takes establishing a relationship of comfort and sharing, and that is not something that you do on the first encounter typically. And improve communication with partner. Bring the partner in, if at all possible. Because that kind of relationship, I think, clearly this is one that needs to have, education going both ways with respect to bringing a partner on board so that he or she will understand the complexity of how this needs to, or the complexity of the situation and how to best make things work better. So, again, sexual dysfunction in MS, the majority of patients discuss sexuality issues with healthcare providers due to, or minority, they don't want to talk about it. Embarrassment or shame feelings, low self-esteem, language barriers, lack of time during visit, all of these features we know well. This is not a 15-minute visit. This is not a discussion or counseling scenario that can take place in a short period of time. So it's however you can make the person's concern, how you can acknowledge it and validate their concern, make them feel valued, and have them come back to address their concerns rather than making a hurried response, suggesting that lubricant's going to be be all to end all for all problems, and see you next year, which I don't think we would do. But it's making time to focus on the problem. All right, so let's talk to Tamara again. The treatment recommendations reframe the paradigm of sexual health. Again, encourage use of diverse stimulation techniques, use of genital lubricants. We talked about, sort of the give and take on that. Suggest taping urinary catheter and lubricating it to prevent it from interfering during sexual activity. And that bottom bullet, I think, is interesting. Following visit, discuss with urologist removal of the catheter and use of intermittent self-catheterization. And then schedule a follow-up visit following wedding. So she comes back. The indwelling catheter has been removed. She and her husband have changed their sexual technique. Bupropion has been added to the medication, and there is a scheduled 1-month follow-up. So points for practice here. You can do, and there are a number of tools out there that can be helpful from a standpoint of looking at sexual dysfunction, and some of them include the abbreviated sexual function questionnaire, which is a 20-item survey. There's the Arizona Sexual Experience Scale, which is a 5-item rating scale. There is the Changes in Sexual Functioning Questionnaire short form, which is a 14-item questionnaire. So it's not about having to, start from square one and taking, an enormous amount of time just to identify the problem. There are a number of tools that can be helpful so that you can, have the patient complete that as she waits for you, or as the couple waits for you to come into the exam room, or as they are out in the waiting room, so that you can sort of hit the ground running and identify the problem or acknowledge the problem and move forward. So we talked about switching things around. We talked about the benefit of anticholinergics, for example, but also the downfall from a perspective of contributing to vaginal dryness. I mean, they'll help dry the bladder, but they also help dry the vagina. So, again, that's a balancing act. And then we talked about the issue of antidepressants, fixing one problem, but maybe contributing to the sexual dysfunction problem as well. So, it's up to us now, as folks who really are the experts in the sexual health arena, to take a long-distance view at the medications and come up with a plan that might be better suited to what we know best, which is contributing to the overall picture of sexual health for this couple. All right, so now we're looking at contraception. So what is she going to do for birth control? What's the plan that's going to suit their family planning prospectus? So she's using condoms right now. She wants a more reliable method that won't exacerbate MS, that will relieve her menstrual symptoms. She has a history of primary dysmenorrhea and heavy menses, and also some symptoms of PMS that began about 2 years ago. So you would like to give her something that's going to not only provide contraceptive coverage, but also the non-contraceptive benefit of treating the heavy menses, the dysmenorrhea, and impacting the PMS or maybe even beginnings of PMDD. So there's no strong evidence to suggest that OCs decrease the risk of MS. Because of the hormonal connection that has been, theorized over the years, there was that theoretical relationship, I guess, or that suspicion that perhaps oral contraceptives might have an impact from a standpoint of decreasing the risk of MS, but there's no evidence, really strong evidence, I should say, to suggest that. There is a little that suggests that OCs might delay the onset, but there's no strong evidence to support it. The results from a standpoint of, do oral contraceptive pills, is there a relationship with pill failure based on what medication she's using? And there is no, again, strong evidence to suggest that that's going to be a problem either. So here are some of the options that she's got. She's got combined oral contraceptives, intrauterine contraception, progestin implant, progestin injection, but she decides to use oral contraceptives because of her symptoms. And she wants a short-term option because she's really thinking about getting pregnant within the next couple of years, and she thinks maybe there will be a positive influence on the MS just based on what she's kind of heard through the grapevine. So all the methods are acceptable for patients with MS. There are no interactions between the OCs and the DMTs. There are numerous drug-drug interactions between medications for symptom management, but nothing that is going to interfere with the efficacy of the oral contraceptive pills, as we now, at least from what what information we have. Conditions associated with MS that might increase the risk of VTE include immobility, but certainly not to the point where we think that the oral contraceptives will be moved into a higher risk category. Okay, so moving on. Tamara has a preconception planning visit. So she's coming in now to talk about the possibility of pregnancy. To review her medications, we instruct her to discontinue interferon beta 1A a month before she tries to conceive. We discuss the effects of pregnancy on MS and look at the issues related to breastfeeding and the need to defer resuming the DMT until after she stopped breastfeeding altogether. So, what happens in pregnancy? So here we have the pregnant person. Pregnancy is associated with an increase in sex hormones, including estriol, 17-beta estradiol, progesterone, and prolactin, which results in a decrease in immunologic activity, especially in the third trimester. Okay? Following delivery, these hormones rapidly return to baseline levels. Pregnancy doesn't appear to affect the overall course of MS, although the frequency of relapses may decrease during gestation, especially during the third trimester, by an increase in the first 3 months following delivery. Breastfeeding is unrelated to the relapse of MS, and some data suggest it might prevent relapses in the postpartum period when the patient is not on a DMT, since these are contraindicated during breastfeeding. Okay? So, looking at outcomes in multiple sclerosis and mean birth weight, maternal MS is generally not associated with unfavorable neonatal outcomes. That's the take-home message. And this is looking at gestational age, and it's pretty much the same thing. Not associated with negative neonatal or delivery outcomes. So in a follow-up appointment, Tamara delivers a healthy term male infant, reports symptoms of MS were significantly reduced during pregnancy and the early postpartum period. She's breastfeeding, and she chooses a levonorgestrel intrauterine system for contraception that's going to be inserted after the 4th postpartum week. So patients should be relapse-free for about a year prior to achieving or attempting to conceive. So achieving a pregnancy or attempting to conceive. DMT should be discontinued a month before initiation of attempts to conceive a pregnancy. All DMT should be stopped in the event of an unplanned pregnancy. You can have an epidural or spinal anesthetic during labor, and breastfeeding should be encouraged, but DMT treatments withheld while breastfeeding. So what happens when you go through menopause? Well, the disease course after menopause has not been well studied. A pilot study that was done in 1992, so a long time ago, found that 19 women postmenopausal completed the survey. Half reported worsening symptoms with menopause. I wouldn't hang my hat on 19 women that were studied in 1992. But somehow out of this data and publications that actually were conducted more recently, or that were published more recently from the Journal of Neurology in 2013, there was a consensus that MS might worsen for a period at menopause and then stabilize. So I guess the point here is that we really don't know. I guess we need to study more women who are perimenopausal and postmenopausal with MS to get a better picture of what that might look like. So a year later, Tamara reports that her mother is menopausal, and she asks what she can expect. So based on what I just said, we don't really have a clear picture, which I think is kind of surprising, to be really candid. I think we ought to be able to have more data than we do on peri and postmenopausal women. But, from what information we do have, we can say, it may increase, your symptoms might increase at menopause and then stabilize. But I'm probably going to do a little more of a literature search as we move forward, or at least look for more publications as we move forward. Hopefully, neurology will generate more data on older women and how well they do, or what their perspective is as they go through menopause. So points for practice: clinicians should evaluate patients' DMTs to ensure that they're taking the appropriate medications. I don't think that as a women's health nurse practitioner or even as adult nurse practitioner, I do that per se, but I certainly do, check to see how well, or at least get a history of how my patients are keeping up with their neurology appointments, and how they're feeling in the course of their disease, and I do that on a regular basis with my patients who do check in with me for well woman visits or GYN-related issues, because their overarching health problem is their MS, and so we discuss that just in the context of their coming in for other things. So I always check in with them about how things are going well or not, and then as see how they're doing with their neurology follow-up. It's interesting that they may have had their neurologist may have retired, which seems to be happening around here, and how well they're doing with their new person. Do they like their new person? Are they are they having insurance issues that have made them have to switch to someone new, or just essentially, are they getting continuity of care with respect to follow-up for their MS? Because I may be the one that has been the most long-lasting and consistent provider in the course of their health. So I think it is up to all of us, even though we may think we're part of that fragmentation care process. I think it's all up to all of us to make sure that whole picture is being managed by someone who clearly is in charge of the chronic health problem, that is in this case multiple sclerosis. Encourage continued vitamin D supplementation, or at least analysis or follow-up on vitamin D and checking levels. Encourage regular exercise, that is in conjunction with what the recommendation is, as is supported by the neurologist or by where she is within the course of her disease, as is standard practice. So I have additional resources here for you: Multiple Sclerosis Association of America, Multiple Sclerosis Foundation, and National Institute of Neurological Disorders and Stroke websites here. And then, again, on the next slide, some more resources. National Multiple Sclerosis Society. These are some more sites for patients and healthcare providers, and then WebMD MS Health Center that you'll see as well. So I know this was a quite detailed look in a very short period of time, and I appreciate your hanging in here with me on this presentation, because I know this is not something we typically get into so much as women's health providers, but as we move to patient home care or medical home, I think it again is imperative that we all sort of keep each piece of this on our agenda to make sure that our patients are getting comprehensive care. So with that, I again thank you very much, and I'm going to turn this back over to the folks that take care of phones and questions and such, and I'm happy to try to answer any questions you might have, and wish you a good rest of your day.
Thank you for your presentation, Dr. Moore. Unfortunately, we've run out of time and we do not have time for questions, but I would like to thank you all for your participation in today's webinar. We would also like to give a special thanks to our presenter, Ann Moore, for her excellent overview on this extremely important topic. In case you were unable to complete it now, you will receive an email from me with a link to the post-test. Please take a moment to complete the post-test to help ARHP assess our educational programming and to receive your continuing education credit.